السلام عليكم. كما قال الأستاذ بوصفيحة، الآن سنمر إن شاء الله لندوة من طرف CSL Behring التي نشكرها كثيرا على دعمها لهذا المؤتمر. أقدم تقديم وجيز بالعربية وبعد ذلك نمر للعروض بالإنجليزية إن شاء الله. ندوتنا اليوم نخصصها لموضوع بالغ الأهمية في طب المناعة والوراثة، وهو أخطاء المناعة الخلقية. ماذا تعلمنا خلال العقد الأخير؟ What we have learned. فقد شهدت هذه العشر السنوات الأخيرة تطوراً كبيراً وملموساً في فهم هذه الأمراض المناعية، كما يطلق عليها حديثاً الأخطاء المناعية الخلقية. هذه المجموعة المتنوعة من الأمراض التي كانت نادرة، غامضة، غير معروفة. كما أشار الدكتور سليمان في جلسة الصباح أنها ابتدأت بمرض واحد اللي هو مرض البروتون، وبعد ذلك تطورت هذه الأمراض لتصير في تصنيف 2024 عبارة عن أكثر من 500 مرض، وكذلك مع بحوث في أسبابها الوراثية. فيصب كل هذا في ابتكار أساليب علاجية حديثة وجديدة، وكذلك شخصنة الطب والعلاج كذلك. سنرى في هذا العالم العربي بدأت ملامح هذا التوجه تظهر تدريجياً من خلال إدماج تحاليل الوراثية، ولنا جلسة غداً إن شاء الله في هذا المجال حول الدراسات الوراثية، كيف نقوم بها وكذلك نتائجها. في هذه الجلسة إن شاء الله سنستعرض العرض الأول الذي سيركز على تطور تقنيات التشخيص الوراثي والمناعي، وكيف أسهمت هذه التقنيات في تسريع التشخيص والوصول إلى رعاية أفضل للمرضى. إذن سأقوم بإعطاء الكلمة للدكتورة إيمان بن مصطفى. She's Professor of Immunology, Head of Laboratory of Control, Transmission and Immunology of Infectious and Institute Pasteur de Tunis, Tunisia. You're welcome, Iman, and the floor is yours.
So it is always a pleasure to be here in the beautiful city of Casablanca and to meet friends and colleagues. And I would really thank the organizers for this exciting meeting, and to thank CSL Behring for the kind invitation to speak at this symposium and to present the progress made over the past decade in screening and diagnostic approaches for inborn errors of immunity. So I disclose partnership with CSL Behring that does not influence the scientific content or the integrity of this presentation. Since the first documented case of inherited immunodeficiency in 1952 in a boy with A-gamma globulinemia, our understanding of inborn errors of immunity has improved rapidly, and over the past decade, we've seen major advances in identifying new genetic defects, understanding the susceptibility to severe COVID-19, and improving treatment. And significant progress has also been made in diagnosis and screening, and greatly improved the ability to detect these diseases earlier and more accurately. So at the early detection step, so I will try to highlight the relevant examples of progress in screening and diagnostic approaches structured around the 4 key steps of the diagnostic assessment. At the early detection step, newborn screening technologies allow to detect inborn errors of immunity before symptoms appear, enabling early detection, early intervention, and better patient outcome. AI-driven tools and virtual consultation platforms help clinicians to better assess the risk of inborn errors of immunity during the clinical evaluation step. Advances in biochemical and immunological methods help also guide PID confirmation. And we've seen major advances in next-generation sequencing and emerging technologies that allow the precise identification of the molecular defect and allow personalized treatment. So the primary objective of newborn screening technologies, population-based newborn screening technologies, is the early identification of asymptomatic infants with severe diseases for which effective treatment is available and where early diagnosis and intervention prevent serious sequelae. And in this regard, newborn screening has been proposed for severe combined immunodeficiency, an important health problem for which naturally known and treatment is available. And since SCID manifests mainly with low or complete absence of T lymphocytes, screening for T-cell lymphopenia was an ideal strategy for the identification of SCID, and TREC, or T-cell receptor excision circuits, was adopted as an effective method to identify T-cell lymphopenia. TREC are small circular pieces of episomal DNA formed during TCR rearrangement. They are stable, not prone to degradation, and did not replicate with subsequent cell divisions, and they are measured by quantitative RT-PCR. Originally, TREC-based newborn screening was designed to detect severe combined immunodeficiency, but it soon became clear that it could also detect infants with T-cell lymphopenia due to other primary immunodeficiencies such as DiGeorge syndrome, ataxia telangiectasia, or Dockade deficiency. It could be also caused by other secondary conditions. To address this lack of specificity and to better assess the incidence of severe combined immunodeficiency and other combined immunodeficiencies, a NICE study proposed a combined approach using TREC assay followed by targeted NGS PID panel. So over 8,000 randomly selected anonymized Guthrie card samples was analyzed, abnormal samples were retested, and if we found low TREC, further analysis has performed, including qPCR for 22q deletion and targeted NGS PID panel. This pilot study demonstrates that targeted NGS PID panel on Guthrie card dried blood spots is a rapid, new, reliable, and cost-effective mutation screening methods for newborn with low TREC count. It also provided the first population-based SCID incidence in Saudi Arabia at 1 in 2,906 live births, which is 20 times higher than in the US newborn screening programs. And it highlights the importance of the implementation of newborn screening for SCID in MENA regions that are characterized by the high rate of consanguinity in order to detect patients earlier and to prevent the burden of infections. Protein-based screening was also proposed to the parallel profiling of 22 complement and granulocyte disorders. briefly, a small fraction of dried blood spots was analyzed from which proteins are eluted. Then they are captured on designed antibody-coupled bead arrays, and the signals are analyzed using fluorescence-based readout. So this technique could be done on a population scale, and it has been tested through the retrospective analysis of patients with confirmed primary immunodeficiencies. And in order to capture more patients, next-generation sequencing-based newborn screening has been proposed, since it concomitantly investigates almost all genetic diseases and is gaining acceptance for genetic disease diagnosis in ill newborns. And in this regard, a rapid whole genome sequencing has been conducted in 35 critically ill infants. Molecular diagnosis has been made in 20 of them, and the diagnosis directly influenced management decisions. So, although NGS-based newborn screening is a powerful diagnostic tool, however, it represents challenges in terms of technology, result interpretation, and cost, and it also raises legal and ethical issues requiring careful consideration. The major advances made during the clinical evaluation step consist mainly in AI-driven tools and virtual consultation platforms. So such advances have been largely motivated by the unacceptable diagnostic delays, ranging from median of 24 months in children and 9 to 11 years in adults, although global collaborative initiatives such as the establishment of 10 warning sites in diagnosis and treatment of inborn errors of immunity. So current approaches begin initially by training an AI algorithm in order to detect inborn errors of immunity using real clinical data from ground truth inborn error of immunity cases, not just oversimplified or typical cases. And indeed, by harvesting data from electronic health records from patients with inborn errors of immunity, AI and machine learning algorithm could identify patterns that are highly indicative of inborn errors of immunity. Then this process could be done in patients who haven't been diagnosed yet, in order to improve the diagnosis and to improve management. Model Foundation has also proposed a two-step analytical pipeline. There is to facilitate the identification of patients with inborn errors of immunity. There is an initial risk assessment with Spirit Analyzer that evaluates the entire population, and it assigns a risk level based on the medical claims data and relevant diagnostic codes. So individuals with high risk undergo further analysis, and their medical claims for each visit are processed through a secondary AI machine learning classifier that calculates what we call a primary immunodeficiency ratio, which is the proportion of high-risk visits among the total visits, and a higher ratio indicate a greater likelihood of having an inborn errors of immunity and enable to address these patients to specialists and allow further clinical evaluation. So this approach ensures efficient risk stratification, early detection, and optimized referral pathways for individuals most likely to have an inborn errors of immunity. Another interesting study proposed a workflow for inborn errors of immunity virtual consultation system to support the diagnosis and management for complex or atypical inborn of error immunity cases, and to support the diagnosis for patients who don't fully meet the established diagnostic criteria. So such system enables remote sharing of patient data and enables the multidisciplinary online consultation among experts. The first step is the clinician that send a new case through the platform. A PID case ID is generated and used for all notification. Moderators can then assign the case to one or more panels of different disciplines. Each panelist can review the case and its documents. Then the panel leader collects all reviews within the panel and sends the preliminary conclusion to the moderator. And finally, the moderator writes the final conclusion and sends the case back to the submitting clinician. So such workflow and consultation system enables to improve the accuracy of the diagnosis and the patient management. So advances have also been made in biochemical and immunological methods, guiding the PID confirmation in the lab, and one of the proposed tests is the calculated globulin, which has been suggested as a viable tool for the identification of patients with potential antibody deficiency. Calculated globulin is derived from the difference between total protein and albumin. It reflects the serum globulin concentration, with immunoglobulin being a major component, and it has been mainly used to detect paraproteins when the level is high. So the potential to use low levels of calculated globulin to detect antibody deficiency have been investigated by a study conducted in adults that demonstrate a linear correlation between calculated globulin and IgG levels. Moreover, the use of a cutoff below than 18 grams per liter for calculated globulin defines a population in which 89% have an IgG level below 6 grams per liter, and as a proof of principle, patients detected with low calculated globulin have been diagnosed with CVID and started immunoglobulin supplementation. This method has also been validated among children and adolescents. So, low calculated globulin may represent antibody deficiency, and we should consider immunoglobulin measurement if there is a history of infections. Functional tests for innate immune defects have also been proposed, since fewer tests were available compared to those for adaptive immune deficiencies, and monocytes represent the archetypical leukocytes for the innate immune response, expressing multiple receptors, sensing pathogen-associated molecular patterns and cytokines. Monocytes produce high levels of TNF after the stimulation of toll-like receptors by LPS and after the stimulation of the intracellular NOD2 receptor by MDP. This response is attenuated by IL-10. Moreover, monocytes could rapidly establish a viral resistance after a response to type 1 interferon. So a study targeted all these signaling pathways using functional flow cytometry approaches after the enrichment of monocytes by means of plate adhesion. And as you see here there is an increase in the percentage of monocytes reaching almost 13% after adherence overnight. So for the diagnosis of patients with defects in toll-like receptors and not two signaling pathways, TNF was measured after LPS and MDP stimulation compared to medium. And delta TNF represents the difference between TNF producing cells after stimulation versus cells incubated with medium, and delta TNF greater than 40% after LPS stimulation and greater of 10% after MDP stimulation are considered cutoff values across healthy donors. So as you see here, IRAC4 patients and MID88 patients demonstrate a complete absence of response to LPS in terms of TNF production, whereas CAP and NOT2 deficient patients demonstrate an absence of response or low response to MDP stimulation. For the diagnosis of impaired response to IL-10, monocytes were pre-incubated with increased concentration of IL-10, then activated by LPS to stimulate TNF production. And as you see here, IL-10 receptor deficient patients show an absence in TNF production, absence of reduction in TNF production as compared to healthy donors. And to identify patients with interferon, type 1 interferon signaling pathway defects, monocytes were pre-incubated with increasing levels, increasing concentration of interferon type 1, interferon alpha, and then infected by recombinant virus expressing GFP. And as you see here, we see in the healthy donors a consistent decrease in GFP positive cells, whereas TYK2 deficient patients demonstrate an absence of decrease, indicating an absence to IL-10 stimulation. So all these different assays could thus guide the genetic screening of the causative gene. Advances are particularly notable in the field of genetics, which seen in recent years the development of DNA and RNA sequencing technologies and the advent of next generation sequencing, be it targeted NGS, whole exome sequencing, or whole genome sequencing, dramatically increased the speed and reduced the cost of DNA sequencing, facilitating the identification of genetic variants at an unprecedented scale. For this, so as a result, genetics are more frequently considered as an early analysis in the diagnostic assessment. Additionally, other technologies have emerged. These technologies are mostly used in research fields, but they are promising and increasingly relevant in diagnosis. These technologies include RNA sequencing, single-cell sequencing, optical genome mapping, epigenetics, and proteomics. And I will not detail all these approaches, but I will focus on two of them. Optical genome mapping is an innovative technique, an emerging technique that uses ultra-long DNA molecules to detect large structural variations in the genome with high resolution. It particularly and especially allows the identification of complex rearrangement missed by standard techniques such as next-generation sequencing, but it's not suited for detecting small mutations, so it is commonly considered as a complementary tool in genomic research and in rare disease diagnostic. RNA sequencing is also an emerging powerful technique to study gene expression and transcriptomic changes due to non-coding and splicing variants. It has been demonstrated that RNA sequencing increases the diagnostic yield by 15% as compared to whole exome sequencing alone. And intronic variants in STAT1, DOC8, IL6ST have been shown to be pathogenic using RNA sequencing. So all this genomic progress and advances allow a marked discovery of variants at a marked increase in variant discovery rate, which is followed by functional testing to prove the functional pathogenicity, and this underlies a dynamic back and forth between genetic and laboratory evaluation that characterize the complex field of inborn errors of immunity. So in conclusion, although newborn screening is crucial for early inborn errors of immunity detection and intervention, it also requires careful consideration for ethical and practical aspects. As in many other fields, artificial intelligence is increasingly involved in inborn errors of immunity diagnosis and plays a critical role in improving accuracy and speed in this complex field. With the increasing diversity of screening and diagnostic approaches in inborn errors of immunity, we should find a balance between efficient and rational use of all these modern testing methods. And advances in screening and diagnostic approaches are driving the discovery of new defects, paving the way for more personalized treatments, which will be covered by the next presentation. And thank you for your attention.
Thank you, Dr. Iman Ben Mustafa, for your great talk. And this is my pleasure to welcome Dr. Rand Arnaout. She's consultant, head section of allergy immunology, King Faisal Specialist Hospital and Research Center, and also professor of medicine at Al Faisal University. She will give a talk about trends in therapeutic management. Please, you.
Assalamu alaikum, and thank you for CSL Behring for sponsoring this session, and which talking about the trends, new trends in the past 1 decade in the field of inborn and of immunity. Dr. Iman just talked about the recent advances in diagnosis, and my second part will be talking about the advances in the management. Of course, the diagnosis and the screening methods are a very essential part of the management, and it starts all there. So once you have an advanced methods of diagnosis, that means the diagnosis will be early and the treatment will be early. In addition, the good analysis, especially in the neurogenetic field, will direct you toward which patient takes who. So the precise medicine, which is now the modern way of doing medicine in this decade. The aerial approaches or historical approaches in treatment of primary immune deficiency were concentrating on using the antibiotics, antiviral, antifungal, and also to replace the immunoglobulins in the patients with immune deficiency, and eventually doing bone marrow transplantation with simply started with a matched sibling bone marrow that is given to the immune deficiency patients. Of course, in the beginning, it was limited options in all the treatments, and the patients, not all the patients can be eligible for these treatments, in addition to a lot of side effects of these treatments because of the primitivity of it. With time, the inborn error, as we all know, they are susceptible for recurrent and severe infections, and early and appropriate antibiotics are essential for the control of the infection, prevention of the complication of the infection, and the survival due to preventing the end organ damage that is coming with the severe infections and unusual infections. The broad spectrum agents, the newer agents that are used for antibiotics are very important. So previously we had only a bunch of antibiotics available for these patients. Now we have some long-acting antibiotics toward especially the resistant organisms like MRSA and gram-negatives, and optimize also the prophylaxis is very important in the patient. So now azithromycin is used as an anti-inflammatory in addition to antibacterial, in addition to the classical Bactrim in the patients, and also using antifungal in certain conditions like CGD and hyper-IgE syndromes. And also the newer generation of antibiotics like levofloxacin, doxycyclines, and others. Also the microbiome are now is important part, understanding the microbiome is important part of the treatment in these patients. So this is just a table showing the different types of immune deficiencies or inborn error of immunities and the recommended prophylactic antibiotics in these patients. So for example, SCID, we are classically know that the patients will need Bactrim or sulfamethoxazole, in addition sometimes to antibacterial, antibacterial, antifungal, and antiviral. And this is very important to prevent their life-threatening condition. In CGD, we also need as part of the regimen, we need always antifungal because of their high susceptibility to all kinds of fungus, and reduce their organ damage, in addition to using interferons. In common variable, especially those with bronchiectasis, they might need as an anti-inflammatory azithromycin in addition to other prophylactic antibiotics. Hyper-IgE syndrome is another immune deficiency that they need also Bactrim or sulfamethoxazole, trimethoprim, and in addition they might need antifungal too, to reduce both the skin abscesses and also the risk of fungal infection in many cases, especially the crypto infection. There are strategies and personalized antibiotic used in IEE. So there are tailored therapy approaches using the pharmacokinetics. So we are doing a lot of monitoring in these patients for the drug levels, for the drug sensitivity, for the resistance that the patients have. And luckily we, for example, in the center where I work, we do the resistance for CMV for the antiviral. We recently also acquired the vancomycin resistance for bacteria like Staph aureus. So basically now, and VREs, so we have now some advanced way of monitoring the drug. In addition, we have also the biofilm penetrating agents, which is important in CVID and CGD with derived relative for a granulomatous infection. There are future directions, of course. Some inhaled antibiotics are already in use, especially in those patients with bronchiectasis, but also there are more agents can be used in the future. And then also the antibiotic stewardships toward balancing the efficacy and the resistance, because resistance and emerging organisms in the field of immune deficiency is becoming a nightmare a little bit. We used to have problems with MRSA, but now also we have other viruses. For norovirus is one of the organisms that are emerging strongly in the patients with the inborn error of immunity. The second line of management, historical and currently, is the replacement of immunoglobulin. One of the major problems in patients with combined immune deficiencies is the lack of immunoglobulin quantitatively or quantitatively or qualitatively, both. So the goal is to restore the level of antibodies to prevent infection, and also or restore the function by giving normal immunoglobulins instead of the malfunctioning ones. And this, the immunoglobulins, historically, they have been, the one we have been using is IV immunoglobulins. One interesting thing that the first immunoglobulin that were used were subcutaneous. But this for Bruton's disease a long time ago, but soon afterwards they vanished from the market and from the screen, and then the IV immunoglobulins were predominantly taking the whole stage for a long time. Until more recently, for maybe the past 15 years, then the subcutaneous immunoglobulin emerged again. And there are also, so we do have now the available for us, the IV immunoglobulins, also some of them with high quality, and also subcutaneous immunoglobulins and the facilitated subcutaneous immunoglobulins. And there are, of course, available to us some special immunoglobulins that are directed towards certain infection, like the CMV immunoglobulins, which we use in our SCID patients frequently, and the HBEG with hepatitis, the VZIG for the varicella, and more recently there are some available for RSV virus, respiratory syncytial virus, and during COVID there were some anti-COVID antibodies that were available for us, but they are vanishing also because of the high mutating virus. This is a list of different immunoglobulins that are available in the market and with their route of infusion or administration. And the manufacturer, and also the their side effects, so their advantages and disadvantages. So I will not go in details in this one. It's available. You can always look at it. I will just now looking at, I will concentrate about comparing between the advantages of subcutaneous immunoglobulin versus the IVIG. So basically, administration-wise, what is given intravenous, so it has to be given in the hospital, while the other one is subcutaneous, so it can be given, there is a freedom of giving it in the hospital or outside the hospital. The frequency of the IVIG is usually 3 to 4 weeks, and for the subcutaneous, it's on a weekly or bi-weekly basis. The peak immunoglobulin level, which is, I think, very important in controlling infection, is it peaks up high and then it goes down to a low trough in the case of IVIG, while in the case of subcutaneous, there is stability in the level of immunoglobulin in the plasma. So this gives a consistency of the viral or antibacterial prevention of infection. The side effects actually, due to the high incidence of there is a higher incidence of systemic reaction, definitely with the IVIG, while in the subcutaneous, the incidence is much lower of systemic reaction, while the reaction is more local rather than systemic. And in addition, I think part of the high side effect is due to the infusion itself, to the immunogenicity, and also to the osmolarity and to the adjuvants or the additives in the preparation, which is we overcome a lot of that with using the subcutaneous. Home administration, of course, feasible not feasible in IVIG, while it's very feasible in the case of subcutaneous. And patient preference, it has to be taken into consideration, of course, always. More patients prefer to take it home with a lot of freedom, to take it whenever he wants, wherever he wants, rather than being strict to a bed for 6 to 8 hours in the hospital. With the improvement in the way we are administering the immunoglobulin and also the lower side effects, this definitely will improve the rate of infection control, and in consequence, the quality of life has been tested before in the patients who were taking the subcutaneous versus the IVIG, and definitely we know that the IVIG has improved the quality of life in the patients with immune deficiency, but definitely the subcutaneous improves that even better due to the gradual absorption and the sustained levels of these immunoglobulins. We come to the third line of management, which is also historical but has improved a lot over the past decades, is the stem cell transplantation in patients with inborn error of immunity. So it is replacing the stem cells that the patient have, the defective stem cells or the absent stem cells, by normal immune cells that are functional and able to protect from infection and autoimmunity and also malignancy. So it's a curative option for many severe cases, not indicated for all kinds of immune deficiency, but definitely the severe ones like the severe combined or the combined like Wiskott and CGD. The goal is to reconstitution of the function of the immune system and prevent and or reverse the organ damage from that happened due to infection or autoimmunity. The timing of the immune reconstitution or replacing the immune system with stem cell transplantation is very critical, and many studies have showed us previously that definitely, especially for the severe cases, who in the general the rule is the earlier the better, no matter when you catch the patient. But for severe combined in particular, it has been shown that if you transplant before 3.5 months, the patient has almost a 98% survival rate. So this is very important to put in mind, but never too late. So I think when you catch the patient and it's possible, just go ahead and do it. The types of stem cell transplantation, the classical one that has been used the most and historically is the matched sibling donor, which is the gold standard due to the low risk of GVHD and other complications with a high success rate in these cases. Now we go to the matched unrelated donor. This is a very important tool for those who does not have a matched donor from the same family like a sibling. And it has good outcomes, but of course this will be on the expense of increasing the risk of GVHD. The haploidentical stem cell transplantation is the more new. Actually, it has been there, but the way it is done has been done in different modalities. For a long time ago, when we have to do it for example, at Duke University, we were doing the precipitation of mature T cells with sheep RBC. biopsies. So it was a crude method, but successful, but it takes a long time. Then there was the CD34 selection, and there was the one with using the cyclophosphamide on day post-transplant day 3. So basically, the method has changed, but the concept is the same. This will provide a donor for every patient, almost just taking half matched. The umbilical cord was fashioned at one time before the haplo became, especially the one with using the cyclophosphamide, became available readily. The umbilical cord was, and it did work for some of the patients. The success was not as good as with everything. Also, there was always the thing that the patient might lose engraftment with time, in addition to the long waiting time because they are immature cells in general. Still, it was a life-saving at one point. So this is what for that. Now, the indication for stem cell transplantation, SCIDs, of course, WISCIT, of course, CGD. There is doubt, but and I think from experience, this one coming in, if you have a definitely full match donor, don't wait too much. And these patients with CGD is in general like a lifetime bomb. So you don't know when they will explode in your face with a very bad infection that is irreversible. HLH, IPEX, severe CVID, of course, you have to put the complication in mind. The comparative table of the different modalities of stem cell transplantation, the match sibling, the donor source is usually from a sibling who is a full match. Sometimes it's a relative, not necessarily a sibling, especially with highly consanguous society like ours. It has the best outcome with the lowest risk and limited donor availability if the family does not have, especially if it's the first child, for example. Match unrelated donor, it's from registry. It has a high success rate if it's well matched. Increase, of course, the risk of GVHD over the matched related. And the donor search time, sometimes it's a very limiting problem. Also, some of the donors, we have faced this one, they will say, okay, we will donate, and then when times comes, they withdraw their names, or they are sick or something. The haplo identical, it's a parent or a half-matched relative, widely available donors, requires graft engineering higher, and it has a little bit and higher rejection risk. Umbilical cord, it's going out of fashion to a certain extent from a cord blood bank. Fast access, no need for perfect match because they are kind of like immature cells. And lower cell dose usually can be a problem. So you delayed immune reconstitution and high risk of infection. Gene-corrected autologous stem cell transplantation. This is from patients' own gene-edited cells. So this takes us to the gene therapy a little bit, which I'll talk about in a little bit. No GVHD, it's personalized, so it's the patient's own cells, still under development for many inborn error of immunity. The future directions in stem cell transplantation as a curative treatment, choosing the modality depends on the urgency, the availability, and the underlying disease. Gene therapy is with the editing of the patient, his own cells, is an evolving field, and we are focusing now on a safer conditioning regimens and to better have prevent GVHD and have universal donor strategies. Now we go to the more advanced part of treatment, which is the gene therapy for inborn error of immunity. Gene therapy involves modifying or manipulating the genes to treat or prevent a disease. And the relevance of it, it's that inborn error of immunity is actually mutations that lead to problems in the immune system. So it offers a potential curative approach. especially for patients lacking a suitable HLA matched donor. Over the past, of course, 2 decades, significant progress has been made in gene therapy. It has been there since the 90s with a lot of obstacles due to malignancies, especially oncogenicity. But now we have more safer approaches and successful stories. Gene editing is another the mechanisms of gene therapy depend on gene addition, gene editing, and also changing the delivery of the manipulated cells or manipulated genes by changing the vector. So the gene addition is involving adding a functional copy of a gene to compensate to a defective one, and the gene editing is directly correcting the mutation at a specific location using the CRISPR mouse. And the delivered methods, of course, the vectors usually, classically they use the retroviruses. Now I think the lentiviruses are becoming more in fashion, but also non-viral methods include techniques like electrocorporation and non-particle delivery system. And I think this method has been used in correcting HAE, hereditary angioedema, by editing the gene and injecting it in the liver, and with great success so far. So,
Dr. would you mind to summarize? We don't have much time.
Okay. So in general, this is looking at different trials for gene therapy, and also the table is available, but it is available for ADA, for X-linked SCID, for WSCID, for chronic granulomatous disease, and for activated PI3K CD, but it is still underway. There is no clear results in the APDS. Of course, it has a lot of challenges because of the safety concerns, especially oncogenicity and the immune reconstitution, if it can be lost after some time with losing the infected cells, and the access and the cost extremely high so far. So basically, it's kind of like make a big limitation on the gene therapy. And there is still ongoing research in order to overcome these obstacles. Targeted therapy is the last part that I will be using for, I'll be talking about in Inborn of immunity. It is actually targeting the function or the mutation by replacing either the molecule itself or trying to antagonize an activated molecule. And more and more of those are available in the past year. That's why the importance comes from diagnosing genetically in order to know exactly what's going on with the patient and target that without having to manipulate the whole immune system. So these are the general methods used: B-cell depletion, T-cell stimulation, cytokine inhibition, complement inhibition, JAK-STAT pathway inhibition, and PI3K pathway inhibition. And this is a list of the different biologics that are available. Of course, classically, we have been using most of those. The most recent one is the linezolid for PI3K. This is still strictly available because the studies are just out last year. And the rest has been, you can see that even we are targeting the T2 inflammation by dupilumab, especially for patients with high IgE and inborn of immunity like DUC8, for example, patients, and DUC2 patients we have some, and with great success of controlling especially the skin manifestation, the allergies, and minimizing the infection. So this is other parts of the treatment of immune deficiency patients that we don't usually talk about, but are so important for the patient. Not only diagnosis and screening, but also advancing research for more treatments. تشخيص الوراثة قبل الزراعة PGD. In addition to gamete selection for this can end the disease, but it has some ethical issues, but this is very important. Social awareness and support, especially with the consanguineous marriages, for families are broken because of this continuous problem. Not nutritional support. Sometimes we do a lot for the patient, but we don't pay attention to their nutritional status, and we might lose our patient from something simple. Clinical pharmacology support for looking at the drug levels, and somebody who monitors the patient's antibiotics and if they are in toxic levels. Multidisciplinary teams like endocrine and psychological support for the patient and their families. And with this, I thank you so much.
Thank you, Dr. Arnaout, for this great talk. I think Dr. Iman will join us for a question. So we are more than happy to take your questions. If there is, yes. Ustad Aziz Bousfiha will, Iman, please.
السلام عليكم، شكرا، عرضين رائعين. سؤال للأستاذة رند الأرناؤوط. أتظنين أنه من الأحسن أن نبدأ بجين ثيرابي عندما نريد أن نؤسس لمشروع زراعة النقي النخاع العظمي، نظرا لأن التقنيات الكلاسيكية قد لا يوجد الدونرز العواقب التي تأتي من بعد وصعوبة علاجها. هل تظنين أن من الأحسن نبدأ بجين ثيرابي؟
سؤال جيد للغاية. I think إنه المشكلة في الجين ثيرابي definitely إنه السايد إفكت لا زالت موجودة. The other thing إنه it's not available for everything. It's for a very limited number of diseases that it's available for. Just not to be outdated or lagged behind, I think we need to go hand in hand. We offer what we have, but also we try to establish the treatments that are emerging without delay. عشان ما يكون العالم كله بيسوي gene therapy, we are still in the doing full matched, sibling. I think it has to go hand in hand, but it's not, the limitation is not only for us, it's for the whole world. So the more with the genetic diagnosis, the more evolving, probably research, probably will have it available, because besides the cost is very high. So until now, I think it's not really readily available for most of the countries. And also, because it's still in experimental, they are highly selective of the patient they are doing gene therapy for. They will not take a patient if they probably anticipate a bad outcome. And we have been facing this with many of our patients. So in general, I think the therapy has to go hand in hand.
I think we have another question.
Yes, thank you to both speakers for these beautiful talks. Maybe one question for Professor Ben Mustafa. You mentioned newborn screening and also artificial intelligence. You separated them. I think maybe I misunderstood, but I think do you think we could one day combine those? Okay, let me rephrase it. Newborn screening using next generation sequencing is already a thing that happens in some countries. They even use whole genome sequencing, which is really amazing. I'm not sure we are there yet in many countries, certainly not in France, for example. But I was thinking, is there a chance that in 10 years, or maybe during the next decade, that we could use these new tools or current tools, and that we could accelerate or shorten the diagnostic delay using machine learning or artificial intelligence in a broader setting in many countries?
Thank you, Nizar, for the question. I don't know if I catch the question. So you mean if we combine AI tools with newborn screening technologies. Yeah, when we see the speed of using using AI technologies in all the fields, and especially in inborn errors of immunity in all the steps of the diagnostic assessment, we could expect to combine, AI tools with newborn screening technologies based using NGS, but NGS-based newborn screening now it only proposed for critically ill infants because it really raises ethical and legal issues. Additionally, there are challenges regarding the delay of the results, confirmation and so on. But yes, AI could be involved in multiple steps in newborn screening technology, but also, as I showed previously, in the clinical evaluation step, in genetic, in the pipeline, bioinformatic pipelines of genetic data. Why not combine it with newborn screening? Yeah,
Thank you. I understand it's not an easy question, and I just wanted to follow up on the expanding universe that the last slide of Professor Arnaud displayed. But I think you agree with the fact that AI could reduce the delay in rendering a result with a gene, NGS using whole genome sequencing, and also helping in deciding whether a variant could be of interest and could be selected as putatively causal, and because we are facing some challenges now to classify some of the variants, and maybe I could help. So not only in newborn screening, obviously, but also in the clinical setting.
Thank you, Nizar. The discussion is very interesting, but unfortunately we have to close the session. And we thank the two speakers for their great talk, and also CSL Behring for their support. So we will have a break right now. Don't miss out e-posters and the other conferences. Thank you. We will give
mes chers amis, salam alaikum.
les trophées to our speakers.
Because photo, لا, she must have two.
Already.
صورة رائعة. شكرا لكم. الآن استراحة حتى 4:10. هناك عرضين مهمين حول جمعية المرضى وما أهمية جمعية المرضى من رئيسة الاتحاد العالمي للمرضى مارتين بيرجان، ثم هناك عرض رائع حول كيف يمكننا استعمال phenotypical classification of PIDs من طرف الخبيرة ليلى جدان. إذن استراحة ممتعة، وبعد 20 دقيقة نلتقي. شكرا لكم وشكرا لسيسل